Pagi semua.
Pagi.
Iya.
Lenggo,
Ya.
ya, mungkin bisa dipandu si Dr. Lipi dan Dr. Bailey untuk menggunakan mood dan juga buat peserta yang lain karena mungkin tadi belum disampaikan.
Oh, oke. Baik, selamat pagi Bapak dan Ibu peserta lecture series hari ini. Kami untuk kegiatan hari ini, kami menyediakan fasilitas penerjemah simultan selama pertemuan berlangsung. Jadi untuk mengakses fitur ini, Bapak dan Ibu dapat mengklik tombol interpretation di bar bawah. Itu di bawah, kalau di saya sih di sampingnya share screen. Ada gambar globe, kayak globe gitu. Bapak dan Ibu dapat memilih Japanese untuk pilihan untuk bahasa Indonesia, dan untuk bahasa Inggris dapat memilih English. Apakah Bapak dan Ibu sudah menemukan fitur interpretation-nya?
Ya, Mbak Lenggo.
Baik, mungkin kita mulai kegiatan ini pagi hari ini. Selamat pagi sekali lagi Bapak dan Ibu. Terima kasih sudah menyempatkan diri untuk hadir pada kegiatan lecture series PPH hari ini yang akan membahas mengenai sirkumsisi medis pada pria untuk pencegahan HIV secara global. Dengan narasumber kita Bapak Robert Bailey PhD dari University of Illinois at Chicago UIC. Sebentar, saya mohon izin untuk share screen. Ya, kegiatan lecture series ini didukung oleh UIC melalui proyek kerjasama training program dalam Advanced Research Method dan Translational Science antara Pusat Penelitian HIV/AIDS Unika Atmajaya dengan UIC. Program ini dirancang untuk membangun kapasitas penelitian HIV di PPH khususnya, dan bagi rekan-rekan peneliti di Indonesia secara umum untuk dapat melakukan penelitian HIV dan AIDS yang inovatif dengan menggunakan metode riset yang advance. Peningkatan kapasitas tersebut kami kemas dalam kegiatan-kegiatan seperti lecture series hari ini, kemudian ada workshop-workshop juga ataupun diskusi-diskusi ilmiah. Jadi lecture series ini akan menjadi agenda reguler kami dengan berusaha untuk menghadirkan narasumber-narasumber baik itu dari UIC maupun dari Indonesia sendiri. Baik Bapak Ibu, mungkin itu sedikit gambaran atau perkenalan tentang agenda lecture series kami. Selanjutnya, sebelum kegiatan lecture series ini kita mulai, saya ingin mengingatkan beberapa hal supaya nanti jalannya acara dapat berlangsung dengan baik. Kita akan mulai sebentar lagi. Di sini mungkin 9 waktu Indonesia bagian Barat, cuman mungkin agak telat beberapa menit. Kemudian nanti pada saat paparan narasumber, Bapak dan Ibu dimohonkan untuk mematikan video dan audionya sehingga tidak mengganggu paparan materi. Dan Bapak dan Ibu juga dimohon untuk mengubah nama atau merename nama menjadi nama garis miring lembaga. Untuk semua peserta juga kami mohon untuk mengisi daftar hadir melalui link yang sudah dibagikan melalui papan chat. Dan jika ada pertanyaan, Bapak dan Ibu dapat menuliskannya di kolom chat ataupun bertanya langsung nanti pada sesi diskusi setelah paparan. Kami menyediakan waktu bagi Bapak Ibu untuk mengajukan komentar ataupun pertanyaan yang nanti akan dipandu oleh moderator. Peserta yang ingin memberikan komentar ataupun pertanyaan bisa melalui chat ataupun bisa bertanya secara langsung menggunakan fitur raise hand. Setelah dipersilakan oleh moderator, Bapak dan Ibu dapat mengaktifkan fitur audio-video untuk mengajukan pertanyaan secara langsung. Baik, saya akan ulangi lagi, pada kegiatan ini kami panitia telah menyediakan fasilitas penerjemah simultan untuk mengakses fasilitas ini. Bapak dan Ibu dapat mengklik tombol interpretation di bar bagian bawah, itu seperti gambar yang ada di slide. Bapak dan Ibu dapat memilih English untuk mendengarkan dalam bahasa Inggris, ataupun Japanese untuk mendengarkan dalam bahasa Indonesia. Keseluruhan acara ini akan direkam dan disiarkan live melalui YouTube untuk kebutuhan dokumentasi kami. Selanjutnya, acara kita ini akan nanti diawali dengan pemaparan oleh narasumber dan diikuti dengan diskusi dan tanya jawab, dan nanti akan kita akhiri dengan penutupan dan foto bersama. Selanjutnya kita akan masuk ke sesi paparan yang akan nanti dimoderatori oleh rekan saya Erik Sindunata MPC. Beliau adalah staf peneliti di Pusat Penelitian HIV/AIDS Unika Atmajaya sejak tahun 2019. Sebelumnya beliau pernah menjadi tim relawan tenaga profesional untuk bantuan psikososial pada bencana gempa di Lombok tahun 2018. Sebelumnya juga pernah menjadi student advisory officer di Universitas Bina Nusantara Alam Sutra tahun 2017 sampai 2018, dan beliau juga berpengalaman dalam melakukan asesmen psikologis dalam rentang waktu 2014 sampai 2016. Baik, untuk mempersingkat waktu, saya akan menyerahkan waktu untuk sesi selanjutnya kepada Erik. Silakan, Kak Erik.
Oke, suara saya terdengar, Mbak Lenggo?
Iya, terdengar.
Oke, terima kasih Mbak Lenggo. Selamat siang semuanya. Perkenalkan dulu, saya Erik Sindunata, salah satu peneliti di PPH yang akan berperan sebagai moderator di lecture series hari ini. Hari ini kita akan membahas mengenai sunat sebagai upaya pencegahan HIV yang nantinya akan mungkin diterapkan di Papua. Nah, seperti yang Bapak sudah tahu, sunat pria itu adalah operasi pengangkatan kulup atau jaringan yang menutupi kepala penis. Penelitian sebelumnya menunjukkan bahwa melepas kulup ini sebenarnya memiliki berbagai manfaat kesehatan, seperti tingkat infeksi kantong kemih yang lebih rendah, penurunan resiko radang, serta masalah kesehatan lain yang terkait dengan kulup. Nah, para ilmuwan mengatakan bahwa sunat pada pria ini mungkin mengurangi resiko infeksi HIV karena jaringan di kulup ini sangat rentan terhadap virus. Area di bawah kulup ini mudah tergores atau robek saat berhubungan seksual. Selain itu, menurut Kepala Penasehat Ilmiah UNAIDS, Dr. Catherine Hankins, dia yang tidak disunat mungkin juga lebih rentan terhadap penyakit menular seksual. Jadi itu juga meningkatkan resiko tertular HIV. Ditambah lagi, daerah di bawah kulup ini menyediakan tempat yang lembab dan gelap di mana kuman dapat berkembang biak. Nah, di sini saya akan menceritakan ada 2 penelitian, yaitu di Uganda dan Kenya, tentang efektivitas dari pencegahan ini. Yang pertama itu di Uganda, yaitu dilakukan di Rakai oleh para peneliti dari Makerere University, Uganda Virus Research Institute, Johns Hopkins University, dan Columbia University, New York. Penelitian ini melibatkan 4.996 pria berusia 15 sampai 49 tahun dan menunjukkan bahwa sunat pada pria dewasa itu mengurangi resiko terinfeksi HIV sebanyak 51%. Nah, selain itu juga ada uji coba yang dilakukan di Kisumu, Kenya. Ini salah satu PI-nya itu adalah Profesor Bailey, yaitu pembicara kita hari ini. Itu penelitian dilakukan dari University of Nairobi, University of Illinois at Chicago, University of Manitoba, dan RTI Internasional. Penelitian ini melibatkan 2.784 pria berusia 18 hingga 20, dan hasil penelitian menunjukkan bahwa ada penurunan sebesar 53% terhadap infeksi HIV. Mungkin nanti lebih jelasnya akan diceritakan oleh pembicara kita. Nah, tapi sayangnya saat ini penerimaan sunat di Papua masih sangat sedikit. DKK tahun 2017 itu hanya 20% pria Papua yang disunat, meski angka prevalensinya justru paling tinggi pada orang asli Papua. Sehingga masih banyak PR untuk promosi sunat di Papua. Ya, nanti mungkin pengalaman Profesor Bailey bisa menjadi masukan tentang cara promosi tersebut. Oke, saya nggak mau berlama-lama lagi, langsung saja ke sesi utama pada lecture series hari ini. Sebelumnya saya akan memperkenalkan dulu pembicara hari ini, yaitu Profesor Robert Bailey, atau panggilan akrabnya yaitu Profesor Bob Bailey. Beliau adalah Distinguished Professor Emeritus dalam bidang epidemiologi di Universitas Illinois at Chicago atau UIC. Selain itu, sekarang beliau merupakan Interim Director di Nyanza Reproductive Health Society atau NRHS di Kisumu, Kenya. Saat ini beliau masih aktif meneliti, menjadi konsultan, dan menjadi Dewan Penasehat dalam berbagai penelitian clinical trial, serta implementasi program terkait pencegahan HIV dan sirkumsisi medis pada laki-laki. Beliau sudah menerbitkan 5 buku dan lebih dari 180 makalah ilmiah terkait pencegahan HIV dan AIDS. Mari kita langsung masuk ke sesi utama lecture series kita hari ini pada Profesor Bailey. Waktu dan tempat kami persilahkan.
Do I begin now?
Iya, silakan Prof. Bailey. Bisa di-share screen?
Okay. There we go. Okay, so I should begin?
Ya, silakan dimulai, Profesor Bailey.
Okay. So thank you for that long introduction, which I couldn't understand, but I'm sure you were very generous. And it's a great pleasure to be here and to be able to speak with you all. I certainly, over the years, have heard a lot about AJCU and ARC, and also I've met a number of fellows that have come from Indonesia to UIC. and even had some of them in my courses. So it really has been many years that I've been hearing about all of you and meeting some of you. So it's a pleasure to be able to talk with you today. I'm going to talk about voluntary medical male circumcision for HIV prevention from a global perspective. And then I'm going to describe a study that some research that we are planning to do. And we're really looking for feedback and for comments and suggestions from all of you. So please, we really welcome your comments. So male circumcision, as you may know, is probably the oldest and most common surgery performed on humans. This is a depiction from Egyptian tomb going back 6,000 years ago. The Egyptians practiced circumcision, perhaps only the elite at first, and then it sifted down to the more common people. And of course, this is where the Jews picked up circumcision and then took it back to their homeland in Israel. I've been accused of seeing something about male circumcision everywhere I go. And so this is one example of that. And you really can, circumcision really is a pervasive topic, particularly when you're obsessed as I am about it. So worldwide, about 35 to 40% of men are circumcised. In Africa, about 2/3 of men, or 68% of men, are circumcised. And it's a practice that's observed mostly for cultural and religious reasons, less often actually for health reasons. But increasingly, people are becoming aware of the health attributes of male circumcision. It's a very simple procedure that probably confers health benefits, but it's a surgical procedure, and so it does entail risks. And so it's very important that when thinking about circumcision, that we weigh the harms or the potential harms against the benefits. It can be performed at any time during the life course. So some societies, they do it in early infancy, others in childhood between the ages of, say, 1 and 10, and then others do it in adolescence. But adult circumcision is primarily for medical reasons. So here's just the male circumcision prevalence in some selected countries around the world. I've highlighted Indonesia. As you're well aware, the great majority of men in Indonesia are circumcised, probably as many or more than any other country in the world. In the United States, about 80% of adult men are circumcised, and that proportion actually is decreasing because of large numbers of immigrants coming from countries that do not circumcise. So for example, Mexico, only 15% of men are circumcised. In European countries like the United Kingdom, about 20%, actually fewer in many of the other European countries, more like 10 to 15%. China, very few men are circumcised. South Korea, almost all men are circumcised, and South Korea is an example of how circumcision customs can change in just a matter of one generation. So prior to the Second World War, few men in South Korea were circumcised, but they picked up the custom from the United States, and now most men are circumcised in South Korea. Israel, as you know, Jews normally circumcised, usually on the 8th day after birth. So most men in Israel, other than the Palestinians, are circumcised. Saudi Arabia, Muslim country. Senegal is also a Muslim country. They circumcise. And then West African countries practice childhood circumcision. So Ghana, Cameroon, Nigeria, countries in West Africa, almost all men are circumcised. In Kenya, where I do a lot of research, 90% of men are circumcised, but there is a region of Kenya that does not practice circumcision, and in that area, HIV rates are very high. And here you can see the other African countries. And in this next slide, you can see these. This is showing the HIV prevalence by country as a function of the percent of men who are circumcised in that country. So you can see in the countries where nearly 100 or from between 75 and 100% of men are circumcised, the HIV prevalence is very low. In contrast, look at those on the left-hand side where very few, only 0 to 10% of men are circumcised, and there the HIV prevalence is much higher. So this was a relationship that was first sort of discovered by Bongartz and Renning and a couple of other teams. They published this work in 1989. And since then, a lot more work has gone into looking at circumcision and HIV. So just looking at the evidence that was available in the year 2000, there were only observational studies. So there were 4 ecological studies that showed that in countries or in societies where most men were circumcised, HIV rates were much lower than in countries or regions where most men were not circumcised. There were 37 cross-sectional studies. There were 7 prospective studies. These were studies where both circumcised and uncircumcised men were recruited into the study. They were followed for 1 to 3 years. And at the end of that follow-up period, they looked and they saw that the rates of HIV were much higher in the uncircumcised men than the circumcised men. And in those studies, they found that circumcision was anywhere from twice as great to 8 times greater. Sorry, that HIV prevalence was anywhere from 2 times to 8 times greater in the men who were not circumcised. And there was a meta-analysis of this work done that found that the odds ratio of circumcision was 0.42. So that means that they found a 58% protective effect of circumcision against HIV incidence. Well, this evidence here was there in 2000, but it was clear to in the international community that that evidence was not sufficient to persuade people that circumcision really could be used as an HIV prevention strategy. So it became clear that it would be necessary to do what are called randomized control trials or clinical trials. And there have been 3 that have been done. One was in Rakai, Uganda, the other in Kisumu, Kenya, which I was involved with, and then the other was in Orange Farm, South Africa. This is just the results from our study in Kisumu, and you don't need to look at this too carefully, but just notice that the blue line is the HIV incidence among uncircumcised men, and the red line is circumcised men. And you can see that after 6 months, certainly after a year, the 2 lines diverge so that you end up with an incidence of HIV in the control group. In other words, the men who are not circumcised, you get an incidence of 4.1%, whereas in the circumcision group, only 1.9% became infected with HIV. So that's a relative risk ratio of 0.41. In other words, a 59% protective effect of circumcision against HIV acquisition. And these are the results of the 3 clinical trials, as well as the observational studies. So this is a meta-analysis. And the size of the red boxes is the sample size. And then you can see that the distance from 1, the left, is the size of the risk ratio. And what's extraordinary is the South Africa trial found a 0.40 relative risk. Kenya, we found a 0.41, and in Uganda, a 0.49. So the overall, when you lump all of those results together, you end up with a risk ratio of 0.43. So that's a 57% protective effect of circumcision against HIV acquisition. And what's really extraordinary is all those studies that were staring us in the face in the year 2000 with the risk ratio of 0.42, almost exactly the same results that we got 6 years and about $30 million later. So one could have argued, as we did in 2000, that the evidence was sufficient, but it really took another 6 to 7 years and $30 million to actually prove through clinical trials, through 3 clinical trials, all of which were very similar results, that circumcision has a protective effect against HIV. So in March of 2007, there was a meeting in Montreux, Switzerland, of the investigators of the 3 trials, plus world experts, world HIV experts. And from that meeting, this statement emerged from WHO and UNAIDS, that the efficacy of male circumcision in reducing female to male HIV transmission has now been proven beyond reasonable doubt. This is an important landmark in the history of HIV prevention. So they said that scaling up male circumcision in certain countries will result in immediate benefits to individuals. So those certain countries are those countries where HIV rates, HIV prevalence is high, and male circumcision prevalence is low. So in those countries, those would be the target countries where male circumcision could have the most benefit. And so male circumcision should be considered as part of a comprehensive HIV prevention package. So remember, this is in the year 2007. At that point, we did not have treatment as prevention. We did not have PrEP. The only things we really had were reduction of maternal child transmission, and then condoms and sticking to one partner, and basically behavioral change interventions. Well, there are other benefits of circumcision besides just from HIV, protecting against HIV. A lot of this work was done as part of the trials, but then additional studies have been conducted as well. So we know that there's about a 50% reduction in chancroid among men who are circumcised. Mycoplasma genitalium, there's about a 40% reduction. Trichomonas, there's a 48% reduction. Genital ulcer disease, there's a 50 to 60% reduction. And that's very important because obviously genital ulcers, ulcerations on the penis or the foreskin, creates an open wound, which then creates a portal of entry for HIV. So genital ulcer disease increases the risk of HIV. So if you can decrease genital ulcer disease through circumcision, that's an indirect pathway towards HIV prevention. And then oncogenic HPV, so human papillomavirus, which causes penile cancer and cervical cancer in women, there's a very large reduction, nearly 2/3 reduction of HPV with circumcision. And then syphilis and HSV2, the evidence is less clear. There's some studies that show a protective effect, some that don't. And remarkably, chlamydia, gonorrhea, and urethritis, there's no benefit of circumcision in protecting those, which are all urethral infections. So it makes sense that cutting off the foreskin is not going to reduce urethral infections. And that finding, in a way, adds strength to the notion that removing the foreskin then has benefits for the other STIs. In women, so the partners of circumcised men, the female partners of circumcised men, have also a tremendous advantage, or there's a protection of the women from STIs. So chlamydia is much less frequent in the partners of circumcised men. The odds ratio of 0.18. So that's about an 82% protective effect of circumcision against chlamydia for the female partner of a circumcised man. Cervical cancer, and this is very important, is that it's about a third to a quarter of the rates of cervical cancer in women whose partners are circumcised. And we can see this regionally too, where in regions where most men are circumcised, the rates of cervical cancer in women are much lower than in areas where most men are not circumcised. So the odds ratio is 0.37, about a 63% protective effect of cervical cancer among women whose partners are circumcised. Bacterial vaginosis, which is a very large problem for women. About 2/3 of women in the world will have bacterial vaginosis at some point during their reproductive life. And it does affect preterm birth, as well as causes a lot of morbidity for women. And the protective effect against BV is about 70 or 60%. Genital ulcer disease is less common in the partners of circumcised men, and also trichomonas. It's about half the rate in the partners of circumcised men. So there are benefits beyond HIV protection that circumcision confers to both males and to females. Well, so once we finished the trials and all those findings were available, then it became time, as WHO recommended, to start scaling up circumcision. And at the time, we really didn't know how it was going to work. We knew how it worked in the trials, but we didn't know how it was going to work in real life when we actually implemented circumcision as a prevention strategy. We wondered, would it be acceptable in societies where most men are not circumcised, where they don't practice traditional circumcision? And then what are the best ways to promote it? Can it be done safely? So in these African countries, the resources in health facilities are not always what they could be. And so is it going to be possible to introduce circumcision and make it safe in these resource limited settings? And then will men get circumcised and then increase their risky behaviors? So if we promote circumcision as something that reduces one's risk of HIV, is someone going to come and get circumcised and then say, I have a natural condom, I'm protected? And thereby will they then increase the number of partners, be less likely to use condoms? And so there's the question of what we call risk compensation. Will they compensate for the lowered risk that circumcision confers upon them by increasing their risky behaviors, their risky sexual behaviors? And then another important question is, if you ramp up circumcision, is it going to detract from other health services? Because as we know, many settings, the resources are limited, both the human resources and the capacity of the health facilities. So this is just a schematic on ways of perhaps looking at a comprehensive or male circumcision for HIV prevention. So in the upper left-hand corner, we have to think about what are the techniques that we're going to use to circumcise. And so are we going to use a surgical technique, or are we going to use devices, clamps, and a device actually that I'll talk about in a few minutes? And then what sites will be ramped up in circumcision? And then who will be the clients? Will they be adult men? adolescents, infants, and then will we be able to recruit men by recruiting couples? And then the mechanism, how does circumcision actually work? Well, as we said, it reduces ulcers. It also reduces trauma. By trauma, we mean scratches, cuts, abrasions. We know that that uncircumcised men have much higher frequencies of scratches, cuts, and abrasions than do circumcised men. And we also know that it reduces sexually transmitted infections. We also know that by cutting off the foreskin, we're reducing the cells that are the target cells for HIV. So when we cut off the inner mucosal surface of the foreskin, when we cut that off, we eliminate a lot of cells, which are then the mechanisms, these are Langerhans cells, the mechanisms for actually, in a sense, capturing HIV and then transporting it to the immune system. And then on the other right-hand side, the advantages of circumcision are, of course, you only need to circumcise once. So instead of taking a pill every day, or a shot once a month, it's a one-time procedure that has benefits for then the rest of one's reproductive life. Adherence is not an issue. Once you cut the foreskin off, you're not having to take a pill every day or use a condom or do other prevention methods. Is it cost effective? Well, there are many models now and studies that have shown that it's highly cost effective. In fact, it's the most cost effective HIV intervention, more cost effective than treatment as care, and female condoms, condom promotion, etc. I won't show those models, but there's been a lot of modeling that has shown that. You also have the opportunity to reach men and partners. So in healthcare settings, often men are left out. Women come to health facilities and they bring children, but adult men often do not go to a health facility. And so this is an opportunity then to access men and to test them for HIV and talk to them about their behavior and behavior change. And then there's the opportunity to improve infrastructure. If we can install male circumcision in a health facility, that will build, we will need things like autoclaves and instruments and couches and lights, all of which will then help to improve the infrastructure of that facility. But there are some challenges. One is, as I said, it's only partially protective. So it's a 60% protective effect. It's not a full vaccine, a 90 to 100% protective vaccine. And so men are still going to have to observe protective behaviors after they get circumcised. Also, safety in resource-poor settings, safety could be an issue. So there's a lot of issues around proper training and proper facilities that are going to have to be, those challenges will have to be met. Then risk compensation. As I said, men may feel like their risk is reduced through circumcision, and so they will compensate by having more risky behaviors. The other problem is, of course, the benefits in the population. The benefits to an individual accrue right away, but in the population, you're really not going to start seeing a benefit for 5 years or so, because it'll take quite a while to get a sufficient number of men circumcised to then, in a sense, have a herd immunity or herd effect, and also to benefit women as well. And then there's the potential for the stress on the healthcare system. So the way we introduced circumcision and scaled it up in many African countries was, on the left-hand side, we recruited men through STI clinics, through voluntary counseling and testing clinics, and through PITC, provider-initiated counseling and testing. And also through schools and through societies or clubs football clubs, cricket clubs, rugby clubs, etc. And then we mainly used peer outreach. So what we got young men who had been circumcised, and then they became the ambassadors to recruit men of the same age. And so these individuals and sometimes couples came, and we provided then these comprehensive services. That's HIV testing and counseling, behavioral change communications. You conduct a medical exam, and through that medical exam, you often find other illnesses or anomalies. And also, of course, you find sexually transmitted infections, which then we can treat. And that in turn not only treats the STI, but also reduces the man's risk of HIV. And then post-surgical care is an important component of circumcision to make sure that the wound heals in a timely and safe manner. And then post-surgical abstinence. So if a man starts sexual activity too early, before his wound is healed, he has an open sore. And so if he starts having sex before the wound is fully healed, he has a portal of entry for the virus, and he increases his risk for HIV. So that post-surgical abstinence period is important, and it's usually about 4 to 6 weeks. And then we can link through those services, we can then link people to other services. So we'll find men who are HIV positive, we can link them to care and treatment. We find some men who have sex with men, we can refer them to MSM support groups, and if PrEP is available, we can provide them with PrEP. For couples and for some men, we can talk to them about family planning. Many young men particularly have drug and alcohol abuse problems. So we can refer them and to other services. And then men as partners refers to counseling men on how to be a good partner, how to be a good husband, how to be a good father. So this is really the comprehensive male circumcision program that was introduced in many areas in Africa. Here is the sort of the scale up of circumcision in Kisumu after the trial was done. And you can see that most of these people who are actually kind of in this parade promoting circumcision, most of them are young men, just the clients, just the participants that we were seeking. Here is a poster from South Africa, and this was one technique for trying to recruit men. It says, "I'm circumcised and I'm proud, but I'm still faithful to my partner." So that's that message of, after you're circumcised, you're not fully protected. You still need to be faithful to one partner. Here's a campaign in Swaziland, which Soka Unkobe, which means cut and conquer. And they chose to try to use young women as means for recruiting young men into the circumcision program. And similarly in Uganda, this is from Uganda, and these are government posters. You can see here again, they're using women, and both older women who are wives, they're on the right, and then young women to make young men really to motivate them to come for circumcision. So, you mean you're not circumcised? Stand proud, get circumcised. So they were really using women as a means of recruiting men for circumcision. And this is consistent with many studies that have shown that actually women in non-circumcising societies often would prefer to have their men circumcised, mainly for issues of cleanliness and reduced risk of infections, not just HIV, but other infections. And this is how, this is just one example of how we provided circumcision. This was at a school in Kisumu. And on the upper left, you can see we had reproductive health counseling. So we provide, information and education to young students about HIV and about reproductive health. And we have group circumcision education in this tent in the middle, upper middle. And then we have individual HIV testing. So individuals get tested in private, confidentially. And then we have the mobile clinic set up on the middle left. And you can see then the surgery. We had tents set up. We set up surgical coaches. We had 6 surgical coaches in one setting and 6 different teams going at once. So we could go into a school, and in one day we would circumcise up to 250 young men. There was also disinfecting as a very important part of the circumcision program. And so we would actually do that on site. We would bring autoclaves to the site and then disinfect them and then dry them, sterilize them. So in Kenya, to date, we've achieved over 1.3 million circumcisions, and our target is 1.6 million. So we're close to the target. And modeling through these procedures, we expect to prevent at least 250,000 new HIV infections over the next 4 years. And here is the cumulative number of circumcisions. This is just to give you an example of what has been achieved in African countries. There's 13 target countries where most men are not circumcised, and HIV prevalence is high. And so up to the end of 2018, we had achieved 22.5 million circumcisions. And you can see the different countries have different amounts of circumcision. We in Kenya were really ahead of everyone for the first several years, but after that, other countries caught up and surpassed Kenya because, of course, they're much larger populations with larger numbers of uncircumcised men. But here you can see how it took a while for the program to take off, but then once it took off, the slope of that line goes up. From about 2012, the program really achieved a lot of success and is still ongoing. So what are the main lessons that we've learned so far from our experiences of scaling up circumcision in 13 different African countries? Well, very important is that VMMC, voluntary medical male circumcision, is a health intervention. It's not an intervention to sort of insinuate the intervention into the culture, or it's not a religious intervention. And that's very important in these societies where circumcision is not traditionally practiced. It's important to convey that the purpose of the program is not to change the culture, and it's not a religiously based intervention. It's really about the health of the community. So persuading elders and religious leaders and local politicians and key people in any society, it's really important to stress that it's a health benefit. It's not an effort to change culture or religion. Another important thing is leadership, both political and cultural leadership. So there are many of the countries that really lagged behind. The reason they lagged was there wasn't the political leadership within the government. There were no advocates in the government for circumcision in that country. And then there were some cultural barriers that really required cultural leaders, leaders in the community, to really understand what the benefits of circumcision will be to their community. And then they become leaders to then lead the members of their community to see what the benefits, the health benefits are. And then it's important for the intervention to be community tailored. That is, to use indigenous models. Those are the most successful. So what works in Western Kenya may not work in Rwanda, which may not work in Johannesburg, South Africa, and that same may not work in, say, Papua New Guinea. So it's very important to understand the local context, not just understand it, but also affirm the local customs, local culture, and make sure that the community is really part of the design of any intervention. And then women are very strong advocates. We've seen that everywhere. And even in Asian countries, when you do surveys of acceptability of circumcision, you find that women are much more apt to accept circumcision and to advocate for circumcision than men are. And then we found that targeting adolescents is the most acceptable and by far the most efficient way to circumcise large numbers of males. And this took a while, but it became so obvious when people were striving as hard as they could to get as many men circumcised. It became obvious that it was adolescents who really were the males who wanted to be circumcised. So why adolescents? Why should we target adolescents? Well, big reason is, of course, that most adolescents haven't begun sexual activity. And so you can get them circumcised before their first or repeated exposures to HIV and other STIs. So if you're going to prevent something, then you've got to prevent it before it actually happens. And with adolescents, although there are definitely adolescents in ages 15, 16, 17, 18 who have begun sexual activity, but the huge majority are not infected with HIV yet. So it's very efficient and effective to target adolescents. Also, adolescents experience less pain than adult males from circumcision. They also heal faster than adult men. And so it's actually easier and way more acceptable to adolescents than to adults. And then it's easy to integrate circumcision interventions with other sexual and reproductive health messages, which are so important to get to adolescents before they begin their reproductive lives, before they become fathers and before they become partners, that you can convey messages to them about their reproductive health and social messages about how to be a good father and how to be a good husband and a good partner. And then adolescents are much more acceptable than adults. Adult men come to clinics almost one by one, whereas in adolescents, you can access them in schools in large numbers and also through sports clubs and other groups, youth groups, that they may be part of. So it's much more efficient, obviously, to be able to circumcise 6 or 7 or 8 boys rather than 1 in a day, because you have a team that you're paying and a facility that is ready. And yet, if men only come one at a time, you have very low efficiencies. So adolescence is much more efficient. And then adolescents can be influenced by community leaders and also by their peers. So once several adolescents become circumcised, they become very strong advocates who are trusted by their same aged, by their age mates. So what we aim to do is to introduce a Papuan indigenous model in Papua New Guinea, an indigenous model for male circumcision. And so the background to this is that, as you all probably know better than I, that Tanah Papua has only 1.5% of the country's total population, and yet it accounts for over 15% of Indonesia's HIV cases. So obviously there's a disproportionate HIV incidence in Papua. Also in Indonesia overall, adult HIV prevalence in 2015, which are the latest data that we could find, it was only 0.3%, whereas in Papua is 10 times higher, namely 3%. So a 10-fold greater epidemic in Papua than in Indonesia, than in the rest of Indonesia. Excuse me. And then in Papua, almost no new infections, or sorry, all new infections occur through heterosexual transmission. In the rest of Indonesia, many infections occur through injecting drug use and by men who have sex with men. But nearly all infections in Papua are transmitted through heterosexual transmission, which of course is just the kind of epidemic where circumcision is going to have the biggest impact. And in Papua, circumcision is little practiced. There are isolated ethnic groups that circumcise, but even in those cases, often they don't practice full circumcision. And so the two conditions for where circumcision is going to be effective in HIV prevention, namely high HIV prevalence and low MC prevalence, are there in Papua. So we think that the introduction of VMM services in Papua could have a significant impact on the HIV epidemic in that region. So our project, our study, has 4 specific aims. The first is to engage the Papuan community and Papuan community members to explore acceptability and the barriers and the facilitators for introducing a comprehensive circumcision program to reduce HIV incidence in Papua. And we'll talk more about each of these aims. Aim 2 is to ensure the capacity of the health system to meet the international criteria for safe, comprehensive services in selected clinics. And then we want to design the Papuan indigenous model of a school-based adolescent circumcision intervention that's based on the information that we collect in aims 1 and 2, but not just the information, the actual partnership with the community in trying to design this intervention. So all along the way, we hope to then have advice and participation by the community, and also the Ministry of Health, the Ministry of Education, and very importantly, parents and other community members. And then the last aim is to then, once we have designed the indigenous model with the community, we then want to do a pilot test of this school-based intervention of VMMC with 400 boys ages 12 to 18 at 2 Papuan locations. One is Nabire and the other in Jayapura. That, at least at this point, those are the 2 places that we are most seriously considering. So what's the approach that we'll be using? Well, we'll be using a community participatory approach, really having community members as our advisors and as our partners in this endeavor. And we want to collect information from people through focus group discussions. That will be with fathers and with mothers, with also the boys ages 12 to 18, who will be the clients or the main targets of the intervention. But we also want to get the opinions of girls of that age, and possibly a few older girls as well. And then, because we're thinking of a school-based intervention, we of course want to involve teachers and school administrators and get their opinions and beliefs around circumcision and introduction of an intervention. Then we'll do in-depth interviews, open-ended interviews with local representatives from the Ministry of Health and the Ministry of Education, but very importantly with religious leaders, with tribal authorities, and with NGO representatives. We really want to get their input and their ideas about how to design this intervention. And we will have a community advisory board. There'll be one from each of the 2 districts, and it'll be composed of a representative of the Papuan Ministry of Health, the Ministry of Education, a tribal authority, an NGO representing youth, school-based, rather a school principal, and then a youth representative and a religious leader. And we'll have that community advisory board in each of the 2 different districts to get their advice and to act as a liaison between us and the community as much as possible. So the second aim is then to ensure the capacity of the community health system to meet the international criteria for safe circumcision services in selected clinics. So what we plan to do is WHO has an instrument for assessing clinics' capacity to provide safe, quality circumcisions. So we're going to assess 6 different facilities for that capacity. Based on our assessment then, we will choose 2 clinics, 1 in each district, to then perform the circumcisions. And we will ensure that those clinics have the capacity to provide the WHO minimum package of comprehensive services. And that, as I've said, includes HIV testing and counseling, treatment of STIs, risk reduction counseling, provision of condoms, and linkage to care and treatment. So if a clinic doesn't meet these needs, then we will put in the resources and train the staff to make sure that they do meet the qualifications. And then aim 3 is to design the Papuan Indigenous model, a school-based adolescent program based on information that we collect in aims 1 and 2. So we will based on aims 1 and 2, we'll collect all this information. We'll then try to design an intervention in consultation with the CAB and with key community stakeholders, as well as the Ministry of Health and the Ministry of Education. And then we're going to perform some feedback sessions where we will get the feedback from parents, youth groups, teachers, and school administrators, what they think of our plan and what revisions have to be made in order. And so we will get their advice and revise the model in response to that feedback. And then we'll pilot test that program, trying to achieve then circumcision with 400 boys ages 12 to 18 at the 2 locations. And so how are we going to do this? Well, we won't know until we actually achieve aims 1 and 2 and get the feedback from the community. But currently we're planning, this is our plan, but definitely subject to revision and input from you all, as well as members of the Papuan community. So first, we intend to give health information talks at the schools. So I showed how we did that. We did that in Kenya and some other countries, and it was very successful. And it's successful not only because it's a way to possibly recruit men for circumcision, but it's also a way to give to the community and provide health information, reproductive health, sexual health, and other health information to young men, males that are in school. And then at the end of the session, we'll ask boys if they would like to participate in this circumcision program. And those who are interested, then we will give them consent forms and a description, which we will have explained verbally, but we'll give them a description, a flyer, to then take home and to discuss this with their parents. They'll also get a number that their parents can call for further information, or their parents can make an appointment and come and talk to us. And So then if the parent and the child or the boy is willing, the boy will come to the clinic. And the boy can come himself or with a parent or his guardian. But if he comes by himself, he must come with a signed consent form from his parent, and with the phone number. So we'll actually call the parent and make sure that the parent does approve of circumcision. We don't want to circumcise boy. We've had this situation actually in Africa where boys come for circumcision and then their parents are furious because they got circumcised without parental permission. So we definitely want to make sure there's parental permission and full informed consent from parents. And we'll encourage parents to come and actually participate and actually be in the room when the boy is circumcised. So parental consent and adolescent assent are crucial. And once that we have obtained consent and assent, the boy will be tested for HIV and will be counseled, and then will be given a physical exam. If he's HIV positive, we will refer him then for HIV treatment and care. He'll still have the option of getting circumcised if he would like. And if he has no physical reasons for not being circumcised, if he's fully healthy, then he's eligible for circumcision. And the technique that we plan to use for circumcision we'll use the Shang ring device. So the Shang ring is a device that has been had clinical trials in China and in 6 different countries in Africa, as well as in the United States. And so the Shang ring consists of 2 rings. There's the inner ring, which goes around the penis inside the foreskin. And then there's the outer ring. Both these rings are made of plastic and they're sterile. But the outer ring then clamps, you apply pressure between the outer ring and the inner ring, and that achieves homeostasis. And so the nerves are blocked and the blood supply is blocked going to the terminal parts of the foreskin. And so at that point, when homeostasis is achieved, the foreskin is cut. And then I'll tell you the advantages of the Shang ring are that it doesn't require suturing. So surgical circumcision obviously requires suturing. Suturing is difficult, it's time consuming, it's costly, and it doesn't give a good cosmetic effect. The Shang ring technique is very easy to teach and very easy to learn. It can be done by nurses, doesn't need to be done by doctors. It's a very short procedure. It takes 5 to 7 minutes to apply the ring, and then only 3 to 4 minutes to remove the ring. The pain is minimal. There's only like a sharp pain for 2 seconds when the device is locked, and then there's another 2 or 3 seconds of pain when the device is taken off after 7 days. As I said, the cosmetic effect is superior. Adverse event rates, the results of the trials have shown very low adverse event rates, virtually no severe adverse events. But the one challenging thing, or the one thing that's different about the Shang ring compared to the surgical circumcision, is the device is worn for 7 days after placement. So it's imperative that the boy comes back after 7 days after the foreskin has been cut and the device has been placed. So they come back after 7 days. So that day 7 is the removal of the device. That time we'll check the wound. We will also ask some questions regarding their experience with pain, their satisfaction with the procedure and with the last 7 days, and then whether they've experienced any ridicule or stigmatization or discrimination by possibly their peers or perhaps some neighbors or even their relatives, for example, aunts and uncles or grandparents, or even their parents. And then, have they had any sources of support along the way? Their parents, maybe some peers, maybe their girlfriend or their sexual partner. And then we'll ask them questions about their sexual behavior since the ring has been on. In 99% of cases, obviously, there's no sexual behavior while the boy is wearing the ring. Then 6 weeks after the removal of the device, we'll do an examination, make sure the wound is healed or is healing properly. We'll look for signs of sexually transmitted infections. We'll ask the boy about his sexual activity and the satisfaction with the procedure, and then whether he's had ridicule, and also whether he feels. Someone talking? Whether his attractiveness has changed, whether he finds that women find him more attractive because he's circumcised, and whether he has started sexual behavior and is practicing unsafe sex. And then the same thing at 12 weeks post-removal, we will do interviews with a subsample. We'll also interview parents at that 12-week visit, and we'll ask them about their satisfaction with the whole procedure, whether they've had difficulties either with the boy or with neighbors and relatives. And then we'll ask them advice on what changes should be made to the program to improve it. And we will also then interview the providers, the people who actually did the circumcisions. We'll ask them about the training they received, about any adverse events they had. We'll ask them their opinion of the Shang ring, any challenges to the health system, and then get their advice on what changes they think can be made to improve the program. So our outcomes, the primary outcome is the acceptability by the board, by adolescent males. So we're going to assess the proportion of adolescent males who are exposed to the school-based information sessions and what proportion of them get circumcised. And then, of course, obviously, safety is very important. So we're going to assess the adverse events from the 400 circumcisions. And we will report any moderate or severe adverse events. And the secondary outcomes are satisfaction by both the adolescents and the parents, sexual activity before the wound is healed. I mentioned the importance of that. Then changes in sexual risk behaviors. Have the boys, at 12 weeks, started increasing their sexual behavior? Are they experiencing risk compensation? And then perceptions of the providers regarding their training and the ease of the use of the device and the challenges that they encountered. So that really is a description of what we're planning. And as I said, we really would like your feedback. But in summary, voluntary medical male circumcision is a proven means of reducing HIV incidence. It's proven through clinical trials and now subsequently through programs. There are many lessons that have been learned during the scale up of VMMC in Africa that can be applied elsewhere. We think that there are many of these lessons that can be applied to Papua as we try to introduce circumcision. And Papua has a high incidence of HIV and a low prevalence of circumcision. So it falls within those target regions for circumcision interventions. And if VMMC is introduced in Papua safely and is acceptable and has the backing of the community, it can have a significant impact on the HIV epidemic. But it is crucial that any VMMC program has the full, not just endorsement of the community, but actual sense of ownership by the local community. And as we do our research, we want to make sure that there's a lot of participation by community members at all levels. So we hope that the pilot study then, if it's successful, that will then lead to a successful larger intervention that's driven by this Papuan indigenous model, where we can scale up circumcision to try to prevent many new HIV infections in Papua. So, I should mention that our study team, Gambit, and I are co-principal investigators on this grant that is funded by the National Institutes of Health. And then co-investigators and consultants are Dr. Judith Levy from UIC, Robert Magnani, sorry, Bob, who will be a consultant, and Laus Rumayam. And then we also plan to have a Papuan project coordinator. That person is still to be named. And then Quentin Awori is the master trainer of Shang Ring. He's done thousands of circumcisions in Africa and trained dozens, if not hundreds, of circumcisers using the Shang Ring in Africa. So I just want to thank all these people who over the years have been involved with me in doing the trials and in scaling up circumcision. This is just a very small subsample of them. And then, of course, those of you who are going to be and have been part of this project, and of course, to thank the funders, Division of AIDS at NIH, as well as the Bill and Melinda Gates Foundation, who have funded a lot of my work over the years. So again, thank you very much. And we really look forward to your feedback and to your comments. So I will end there.
Terima kasih Profesor Bailey atas paparannya. Before we start the discussion, I would like to make sure that Professor Bailey can hear the interpreter. Can you hear the interpreter?
Yeah, I can hear you.
No, no, the.
No. Let me stop
interpreter.
sharing my screen. I don't hear anyone but you.
Okay.
Bob, are you hearing the English?
No. Well, I mean, here no, I'm not hearing any translation.
Okay. You can access it from the button in the below that looks, yeah, that
interpretation
that looks like a globe.
Okay,
and you can choose the English one.
Okay. Okay. Can you test it or?
Yeah. Apakah sudah
Yes.
terdengar?
Yes.
Yeah.
Great.
Okay.
Thank you.
Okay. Terima kasih Prof. Beri atas paparannya sekali lagi. Sekarang kita akan masuk ke sesi diskusi selama 45 menit. Nah, kepada teman-teman yang ingin bertanya, silakan gunakan fitur raise hand untuk bertanya langsung. Itu nanti silakan aktifkan videonya dan di-unmute suaranya. Ada beberapa pertanyaan di kolom chat, mungkin nanti akan kita bahas satu-satu. Silakan pertama untuk Mbak Basaria, Ibu Basaria, sudah mengangkat tangan.
Yes.
Lalu Ibu Angela setelah itu. Mungkin satu lagi. Oke, jika tidak ada silakan Ibu Basaria terlebih dahulu.
Yeah. Thank you. Good morning, Bapak, Mr. Bailey.
Good morning.
Yes, I wanna ask. We are in Danau Toba, Toba Lake, North Sumatra. We are from Hospital of Tarutung, and we want to ask you several questions. First, is the circumcision that you mentioned with the ring and with the band, is that not make prolong procedure, because we have to wait the client to come again in a week later? Is that a more efficient and practice if we use the suture way, the conservative way? And then the second, in our community, in our culture, circumcision is not our habit, because mostly in North Sumatra or in Tanah Toba is a Christian religion. So what your suggestion to us to make a good promotion about circumcision? Because if we want to make promotion only based on health, it's not so accepted secara cepat. We can have a good acceptance in program. Thank you, Bapak.
Okay, thank you for your questions. Yeah, the Shang ring, it's true, it does necessitate that 7 days from when it's placed to the removal. But with surgical, first of all, it's very quick. So as I said, it only takes 5 minutes to place the ring, compared to a surgical procedure, which takes usually anywhere from 15 minutes to 45 minutes. Also, you can use a topical anesthesia with the Shang ring, whereas with surgical, often you'll need a dorsal block or a basal anesthesia. And that, of course, increases the danger, the risks of the circumcision when you're doing that dorsal block. Also, with a surgical procedure, at least by WHO standards, I don't know if you all make the person come back to check the wound and to change the bandage, but certainly the best practice is to have him come back to change the bandage and to check the wound. So having him come back after 7 days isn't that much more of a burden than surgical circumcision in terms of an extra visit, right? In terms of promoting circumcision in your community, which is primarily Christian, if the community, senses that Christians should not be circumcised, I mean, that we've seen that in other societies as well. There's nothing in the Bible that says that Christians should not be circumcised. And as we know, of course, Jesus Christ himself was circumcised. But if that's the prevailing opinion in the community, I think the important part is to really emphasize, the aspect of health and how not just health for the boy, but also for his family, for his female partner, for his wife, and then also for the community at large. Because if you increase the cleanliness of men, you reduce their infections, you're reducing it not just in that man, but in the community at large. And as I said, we have found in many places that women are really the strongest advocates for circumcision because they are really tired of their men being dirty and not clean, but also carrying greater risk of infection for the woman. So women in that setting might become very strong advocates for circumcision.
Oke,
Thank you, Pak. Thank you for your explanation.
selanjutnya Ibu Angela, habis itu Ibu Yeri dan Ibu Caroline ya.
Okay, Dr. Billy, I have some questions. Like you mentioned that the medical circumcision already implemented in several African countries, and the risk compensation is the big problems with medical circumcision. Like based on your experience, like how could you like minimize or reduce the risk compensations? And for the second questions, like for the pilot study in Papua, you will use like school-based approach. So I'm just wondering, is there any problem like with like selection bias between like students who, like adolescents who are in the school and also like outside the schools, because like maybe they have like different sexual behaviors between like more educated and not educated adolescents. And for the third one, the Shang, I'm just curious, like how is like the sustainability for the Shang compared to surgical circumcision, because you know like in Indonesia it's not common like for Shang. Thank you.
Yeah, good questions. In terms of risk compensation, while risk compensation, is a possible challenge, we have done a number of studies to look and see if men who get circumcised start engaging in higher risk behaviors than men who do not circumcise. We actually did a prospective study with my student Nellie Westerkamp, PhD student, over a 2-year period. What we found was actually that the circumcised men reduced their risk behaviors. Instead of increasing their risk behaviors, they reduced them. And for several reasons. One is, we do a lot of counseling during the circumcision program. So they're coming, they get counseled, and then they're coming back for their check, their wound check. And at every one of those points, we counsel them. And we try to help them then talk about risk reduction. But the other is, of course, the men who come to get circumcised, they're motivated. They wouldn't want to be circumcised unless they were already motivated to try to reduce their risk. So we found that over a 2-year period, the men who were circumcised actually used condoms more, they had fewer sexual partners, and they had less sexual unprotected sex than did the uncircumcised men. So instead of risk compensation, the other way to think about it is maybe actually there is decreased risk in the circumcised men. And then the school-based program, you mentioned bias. Well, we're not so concerned about bias in the sense we're not trying to get a random sample of adolescents to get circumcised. We're really trying to see what boys will get circumcised, and then we'll study the characteristics of those boys. Maybe they'll be younger, maybe they'll be poorer, or maybe they'll be better educated or less educated, or maybe they'll have 2 parents and instead of 1, so we can look at the characteristics of the boys who do accept circumcision versus those that don't. And then I think that's, so then the issue is, what about the boys who are out of school? Well, as I said, we find it's very efficient to access the school boys, but definitely boys who are out of school will be eligible for circumcision also. And we hope that some of our peers, some of the peer outreach workers who we will train, will also do outreach not just to schoolboys, but to boys who are out of school also. And it's a very good point. It's very possible, in fact, probable, that boys who are out of school may be at higher risk than boys who are in school. So it will be important to see if we can recruit some out of school boys. Then the Shang ring, yeah, so that is the issue. There is the issue of procurement, right? I mean, with surgical procedure, you really can use pretty much all the devices, all the resources and the equipment that are available in a clinic. So whether it's sutures or the scalpel or bandages, those are all available. So having to procure the Shang ring does add an extra dimension, but there have been studies looking at cost, and even having to pay for the Shang ring, because of all the other things that you don't need, the Shang ring circumcision actually ends up being less expensive than a surgical circumcision. So, but it would take a commitment on the part of the Ministry of Health, you know, or at a provincial level or a national level, to be committed to the continuous supply, procurement and supply and distribution of the Shang ring. That is true, and that is a possible, you know, challenge.
Thank you, Dr. Bailey.
Oke, ada 3 pertanyaan lagi, 4 pertanyaan lagi. Mungkin nanti satu persatu ya. Untuk selanjutnya, Ibu Yeri Pergata atau Bapak Yeri Pergata, dipersilakan. Teman-teman bisa menggunakan bahasa Indonesia karena nanti akan diterjemahkan ya jika ingin menggunakan bahasa Indonesia. Silakan Bapak atau Ibu Yeri. Boleh di-unmute dan ditampilkan videonya.
Jadi jalan lebar itu. Saya boleh Pak?
Iya, silakan. Videonya boleh di.
Baik, makasih atas kesempatannya. Perkenalkan saya Yeri dari Yayasan Air Insan Anugerah Insan Residivis Pak, yang berfokus programnya itu di lapas kriminal sama narkotika laki-laki dan perempuan, tapi kebanyakan ini laki-laki. Kemarin kita udah audiensi sama PPHU Aceh tentang ketertarikan kita lebih ke penelitian penularan HIV di dalam lapas, terutama dalam lapas laki-laki yang over kapasitas gitu. Kebanyakan LSM di kita itu lebih cenderung ke narkotikanya saja, sedangkan di kriminal juga tidak menutup telinga mata kita gitu ya. Terjadilah di situ perilaku beresiko seksnya gitu. Apakah Mr. Bailey tertarik untuk melakukan penelitian tersebut? Terima kasih.
Yeah, so that's a good question. I assume that most of these prisoners are engaging in sex with other men, right? So if that's the case, then circumcision will not have a protective effect, or will have a minimal protective effect among these prison inmates who are practicing sex with other men. When you think about it, the primary means of HIV acquisition in men who have sex with men is through anal intercourse, and it's through the anal mucosa that men are getting infected. So circumcision under those conditions would not have a very large impact on the HIV incidence in that setting. It might, but I must say that prisons are a place where, of course, obviously there are a lot of men congregated, So it could be possible to offer circumcision to prisoners who are not long-term prisoners, because if they're going to get out of prison and be sexually active with women, then it may be a good venue for introducing circumcision. However, you have to be careful because often prisoners can be coerced or considered to be coerced, and you don't want to coerce people or men to be circumcised. It must be voluntary. I hope that's answered your question.
Apakah terjawab, Pak Giri?
Baik, terima kasih Mr. Bele. Terima kasih moderator, terima kasih Wajib.
Oke, terima kasih Pak Giri.
Thanks for the question.
Untuk pertanyaan selanjutnya Mbak Caroline, silakan.
Mervin, maaf nggak bisa aktifin video ya. Professor Bailey, in some provinces in Indonesia, community-tailored or indigenous models are highly considered, not only in Papua. For example, because circumcision does not only perceive as medical intervention, but also traditional practice. In East Nusa Tenggara, for example, in a place called Antonimeto, traditional circumcision is still performed by removing the foreskin using bamboo. This unique practice is that after the traditional circumcision, post-surgery abstinence is not suggested, but in fact, post-surgery sex is compulsory. So the circumcised men are supposed to have sex with a quote-unquote assigned person, which is not the partner, not their sexual partner. In the olden days, a certain female are assigned to this role. But nowadays, sex workers are called to help with the practice. So risk of STI and HIV, of course, is higher because of this practice. One particular note on this is that the engagement of traditional healer or indigenous leaders is important in this study to make sure that the study is also culturally sensitive. One more note, maybe to add up to Jerry, the one who questioned before me, is that bead implants, or we call that TASB, is usually inserted in the those who have been in prison. They usually insert we call that TASB, but it's actually a beads made of sharpened. How do you call that? Sharpen a toothbrush, the stick of the toothbrush, and then they insert it inside the foreskin to increase the sexual pleasure once they got out, to increase the sexual pleasures with their partner. So maybe one of the concern also asked by Jerry, if I'm not mistaken, is that maybe besides people in the general population, also include people from the who have been in prison or have been post-release.
Well, that is fascinating. It's just the kinds of comments and information that we need. This practice of a boy after he's circumcised, rather than being abstinent, he's actually supposed to have sex with a woman. Often, there's the same in certain African societies as well, where there is a woman who's designated, as usually an older woman, who then the boys are supposed to have sex with. And of course, she's had sex with many other men, and so often she is HIV positive, and so it's a really easy mechanism for spreading HIV. And there have been interventions to try to reduce that practice, and we may have to do the same. The crucial thing, of course, is having the political and the religious leaders and the elders in the society understand what the risks are, and to lead be the leaders or the lead advocates for changing those customs. Things like this we need to know much more about, and I'd be glad to learn a lot more. It sounds like you have a lot of information that would be valuable. Thank you.
Terima kasih, Mbak Caroline. Selanjutnya Pak Mozart, silakan.
Ya, selamat siang Pak Prof dan teman-teman. Sedikit pengalaman yang kami perlu sampaikan untuk kita semua, terutama bagi akan jalannya proyek yang akan dilakukan di Papua ya. Suara saya dengar?
Terdengar Pak, silakan.
Oh ya, ya. Untuk sirkumsisi pria sukarela di Papua, kebetulan Bang Sepnat juga ada. Ini salah satu tokoh kami dalam program sirkumsisi juga. Memang benar kalau pada komunitas-komunitas tertentu atau daerah-daerah tertentu seperti Papua, kita sangat membutuhkan waktu dalam hal untuk bagaimana mensosialisasikan kepada masyarakat terkait dengan penerimaan sirkumsisi di dalam masyarakat yang tanda kutip dia punya komunitas basis yang berkaitan dengan religi atau agama. Memang bahwa pelaksanaan sirkumsisi untuk pencegahan HIV atau penyakit menular seksual yang lainnya tidak perlu untuk melihat agama atau lihat dari sisi agama, karena ini tujuannya adalah untuk kesehatan manusia. Tapi hanya bahwa kemudian kita di berbagai daerah punya kearifan lokal yang memang kita benar-benar akan berbentur dengan situasi itu. Pergumulan kami di Papua itu kurang lebih 5-6 tahun untuk bagaimana menabrak tembok besar secara khusus yang agama. Kalau secara budaya ada beberapa daerah yang punya kebudayaan yang berkaitan dengan sirkumsisi. Tetapi kemudian bahwa program seperti ini dia bisa berhasil, itu komunikasi informasi ya, sosialisasi itu memang harus benar-benar dilakukan. Jadi tidak hanya sebatas penyampaian informasi dengan brosur atau dengan kita harus berhadapan dengan tokoh-tokoh penting. Kami di Papua melakukan kajian-kajian ini dengan para pemuka agama, pendeta, baik itu yang ahli perjanjian lama maupun ahli perjanjian baru. Kami bersama melakukan pertemuan dengan denominasi gereja untuk membicarakan ini. Nah, kita bersyukur bahwa dalam rangka pencegahan HIV itu mereka terima. Tetapi tidak sampai di situ, kami juga lakukan studi. Kami lakukan studi bagaimana masyarakat menerima program sirkumsisi itu sendiri. Yang berikut kami harus menyediakan tenaga-tenaga terlatih. Kami mengirimkan tim medis dan tim sosialisasi ke Uganda, ke Afrika, untuk melihat bagaimana mereka kerjakan sirkumsisi di sana. Kembali dan kami juga melakukan membentuk tim Pokja, kelompok kerja, yang kemudian kami melatih para medis, kami melatih lagi tim kampanye untuk turun ke daerah-daerah. Jadi berdasarkan itu, lalu hasil studi studi kita lakukan, hasilnya datang, baru kita lihat bahwa ini memang masyarakat menerima, ya, masyarakat menerima yang tujuannya adalah untuk menyelamatkan orang Papua. Tanda petik bahwa kalau di Papua itu bukan saja kita lihat dari sisi agamanya, tapi budayanya juga. Lalu intervensi ini kita lebih fokus kepada memang benar-benar kami punya masyarakat asli Papua. Ya, kami bekerja demikian, dan sampai saat ini sebenarnya program sirkumsisi sangat diminati, Pak. Sangat diminati sekali, hanya saja ada sedikit problem dengan kebijakan, ya, sehingga lembaga yang membawahi program ini dalam hal ini adalah KPA Papua itu menjadi lesu, tetapi kami tidak menyalahkan seperti itu. Bahwa kemudian Dinas Kesehatan sebagai lembaga yang membawahi layanan kesehatan, itu mereka sudah siap juga. Jadi mereka siap. Oleh karenanya saya usulkan kepada Prof atau teman-teman dari Atmajaya ketika proyek ini akan diluncurkan ke Papua, alangkah baiknya undang Pak Konstan Karma sebagai tokoh sirkumsisi di Papua, lalu kita libatkan beberapa tenaga terlatih, tenaga medis terlatih, teman-teman di Pogja sirkumsisi, ada pendeta pendeta Sevnat, kemudian ya Dinas Kesehatan sama Rumah Sakit Dok 2, kita duduk berbicara tahapan mana yang kita harus lakukan. Jadi kita sudah tidak bisa lakukan lagi dari awal. Itu nanti pasti akan kena benturan. Jadi usul saya untuk tim nanti bahwa untuk Papua siap menerima proyek ini. Hanya supaya jangan terjadi benturan, kita harus duduk bersama kembali untuk mendesain mulai kita start dari mana. Saya rasa kelompok sasarannya tepat, Pak. Karena kami ketika itu dalam program kami akan nyasar anak-anak kita atau remaja-remaja kita di basis sekolah. Tadi ada pertanyaan dari salah satu saudara dari Medan, bagaimana dengan yang di luar sekolah? Nah, ketika kita tangani yang di sekolah, maka di luar sekolah pun kita akan bisa tangani lewat LSM peduli untuk membawa mereka kepada layanan sirkumsisi. Di Papua sudah punya klinik sirkumsisi di salah satu rumah sakit Dok 2, bahkan Merauke, Kabupaten Merauke, Kabupaten Jayawijaya, dan Nabire itu sudah siap sebenarnya untuk melakukan atau melaksanakan program ini. Jadi usul saya untuk kelancaran ke depan dan sukses daripada proyek ini, ya undang Dokter Hewan Konstan Karma sama beberapa teman-teman kita yang sudah memang melakukan program ini. Barangkali itu Mas Erik, Pak Prof, terima kasih.
Oke, terima kasih Pak Mozart. Selanjutnya Pak Sevnat, silahkan.
Can I respond?
Ya, oke.
Oh ya, boleh, silahkan Prof. Ya.
Yeah, thanks so much for all those comments and for and the background. And I know obviously it sounds like you have a lot of experience, and that we do not intend to just walk in there and start a program. It's going to take a lot of preliminary work and consultation. And actually, Konstan Karma is part of our team. He's been contacted, and if I'm not mistaken, Judith or Gambit, you can tell me, but I believe he's on going to be chair of our community advisory board. But in addition, yeah, I mean, there's a lot of preliminary work to be done, both with the community and, with stakeholders and NGOs, and then also with the Ministry of Health, the local provincial Ministry of Health, and the clinicians. And if you say there is a place where that already is doing circumcisions, we definitely would like to visit them and learn from their experience, and make sure that experience is really part of what we try to plan and how we try to design the intervention eventually. I'm glad to hear that you think that adolescents and in schools are an appropriate and good target for us.
Oke, ya, terima kasih Profesor, terima kasih Pak Mozart. Selanjutnya Pak Sevnat, lalu pertanyaan chat dan Pak Denden terakhir ya. Silakan Pak Sevnat.
Ya, selamat siang semua. Terima kasih Prof. Terima kasih untuk kegiatan hari ini, karena ini pertanyaan yang disampaikan kepada saya oleh Dinas Pendidikan, Dinas Kesehatan, dan Pak Konstan Karma di awal tahun ini. Di awal tahun ini, kapan kegiatan ini berjalan? Dan saya berterima kasih hari ini sudah ada. Yang hanya saya ingin tanya, Prof, waktu penyampaian pertama kalau tidak salah itu ada pergantian tempat. Yang pertama itu kan rencana Jayawijaya, Nabire, dan Jayapura. Tetapi kemudian terakhir itu informasi ke saya untuk mendapat dukungan dari Dinas Kesehatan Provinsi Papua dan Dinas Pendidikan Provinsi Papua, itu Jayapura dan Kerong. Jayapura dan Kabupaten Kerong. Dan itu yang saya, Dinas Kesehatan Provinsi, Dinas Pendidikan, dan Pak Kostan Karma membahas itu. Kalau memang ada perubahan untuk Nabire, kami akan bekerja untuk menyukseskan hal ini, karena seperti yang sudah disampaikan oleh Pak Mosat, bahwa ini adalah perjuangan 10 tahun lebih. Teman-teman Pak Karma, Pak Mosat, mereka berjuang untuk berhadapan dengan kami tokoh-tokoh agama, bagaimana membuka ini, karena ada pandangan-pandangan teologi di sana. Itu sehingga kami sangat mengapresiasi kegiatan ini di Papua, karena ini juga menjawab keberlangsungan program yang sudah dirintis oleh Pak Kostan Karma dengan Pak Mosat dan teman-teman di KPAP waktu itu. Hanya ya karena pandemi, rencananya kalau nggak salah Prof ya, rencananya tahun 2020 itu kita sudah harus jalan. Tetapi ini karena pandemi sehingga ini terjadi. Itu aja yang saya ingin mengklarifikasi, apakah memang kita tetap di Nabire seperti yang disampaikan, ataukah yang terakhir supaya mendapat surat rekomendasi dari Dinas Pendidikan dan Dinas Kesehatan yang saya sampaikan di Kerong. Terima kasih Prof. Silakan.
Thank you. Yeah, I'm not actually the person really to answer your questions, except to say that, you know, obviously the COVID epidemic really took us by storm and has made it very difficult to make concrete plans. I can tell you that we are putting together all the documents for application to institutional review boards, both in the United States and in Indonesia. And that is going forward, but in anticipation that someday we're going to be able to travel and to start a program, you know, without too many difficult barriers in place because of the virus. As for Nabire, whether Nabire is the site or not, I'm going to let Gambit address that issue, because I'm not familiar with, I'm not very familiar with the geography, but definitely not with the personalities, the relationships, and the governmental relationships. But I do want to thank you for being helpful and trying to look ahead in what kinds of permissions and approvals and partners that we're going to need to be successful. I don't know if Gambit could jump in and address the question about Nabire.
Apakah Mas Gambit mau menanggapi?
Ya, Prof, nggak jadi masalah entah Nabire atau Kerom. Yang pasti jika itu sudah menjadi hal yang harus kita kerjakan, maka kita akan kerjakan bersama-sama. Terima kasih.
Great. Thank you very much.
Oke, Prof. Mungkin ada beberapa pertanyaan dari kolom chat. Ini, apakah silikon injection kepada penis itu berpengaruh pada sirkumsisi? Lalu, apakah jika tetap dilakukan sirkumsisi itu apakah bisa? Dan apakah infeksinya akan bisa berkurang jika ada silikon itu?
Yeah, so I'm an epidemiologist, not a clinician. I think what really matters is the condition of the foreskin. And sometimes silicone injections can affect the action of the foreskin, whether it's increasing the odds of phimosis or paraphimosis, in which case actually circumcision would be indicated. It would be best to circumcise the man if he has phimosis or paraphimosis. But it really comes down to what's the condition of the foreskin. Is it retractable? And I would think that there would still be the same benefits to circumcision for a man with silicone injections as for someone who doesn't, because you're cutting off the target cells for HIV, and so the protective effect should be similar.
Sebenarnya waktu kita sudah habis, tapi masih banyak pertanyaan. Apakah boleh kita lanjutkan lebih dari jam 11 atau bagaimana?
Kak Erik?
Ya, silakan.
Kayaknya ini mungkin waktu di Chicago juga.
I can go for another 5 minutes or so. Another couple of questions.
Oke, 5 menit ya. Oke, untuk ada pertanyaan dari Rosa Delima. Ini apakah I misunderstood or misheard this matter, but I heard within this presentation that circumcision is a form of surgery that also has risks. What are the risks here, and does it have different kind of risks compared to any other small surgery? And the other question is, may I know more about how did South Koreans change their custom to promote circumcision? And does the same strategy work in Africa? If not, what were the challenges?
So the risks of circumcision. Oh, sorry. Do you want to translate into Bahasa? So you want me to go ahead?
Oh, okay.
Yeah.
Ya,
Do you want to translate first?
Oke, saya translasi dulu mungkin ya. Jadi di presentasi tadi ada yang mendengar bahwa itu adalah operasi yang mungkin menyebabkan resiko gitu. Resikonya apa dan apakah resiko itu mirip dengan operasi kecil. Terus pertanyaan keduanya, bagaimana di Korea Selatan ini dipromosikan untuk sirkumsisi ini, lalu apakah strategi itu bisa dilakukan di Afrika, dan kalau enggak, itu apa aja tantangannya? Seperti itu. Silakan, Profesor Belly.
Yeah. So the risks of circumcision, are very minor if the practitioner is well trained, and has the resources necessary to perform the circumcision. But the risks generally are pain, bleeding, infection, and also an adverse reaction to anesthesia. And then the worst case is mutilation or even loss of at least part of the penis. The mutilation and loss of part of the penis is exceedingly rare, but probably the most common adverse event that has been seen in Africa after 23 million circumcisions is actually minor bleeding. So the man will get circumcised and then will come back 1 or 2 days later, and the wound is bleeding. And that's particularly with surgical circumcision. A stitch breaks, And so then the person bleeds. Often that's addressable just by putting pressure on the wound. With the Shang ring, adverse events are much less. So bleeding is very infrequent, and mutilation is virtually not possible. And then, infection, there can be infection because the ring is there, left behind. But if the wound is properly cared for, infections are few. And infection is not a serious adverse event because it can be addressed, often with topical ointment, but also with antibiotics. So the risks are really quite minimal with circumcision. In terms of South Korea, well, the South Korea really converted to being a circumcising country during the Second World War and then during the Korean War, because this happened also in the Mideast and particularly in the North African theater. When men were not circumcised in the North African theater, they got sand under their foreskin, and then that became infected and they had balanitis. And so actually Rommel, the German general, wrote in his diary that I've lost 15% of my men, they're all in sick bay because they're having to get circumcised. So it was really during the wars that circumcision became more common. And in South Korea, the South Korean army then took it up, got it from the American army. And then those men who came out of the army then went back to their families and they had sons, and then they circumcised their sons. So literally in one generation, there was a dramatic change.
Oke, kalau tadi ada pertanyaan juga tentang apakah itu bisa diterapkan di Indonesia atau di Afrika waktu itu. Prof.
Well, probably not. I mean, what we're talking about is an army doctors then performing a lot of circumcisions, and I guess the army providing the model for other men, and also circumcising large numbers of soldiers who then go back into their community and advocate for circumcision. I don't think we want to start a war in order to have a lot of soldiers circumcised under war conditions, but I think the reason that the men during war got circumcised was purely for health reasons. And as I've said, repeatedly, I think that is the most important thing to stress, is that circumcision is for health reasons and not just for the man, but for the entire community.
Terima kasih Prof. Feli. Maaf Bapak Ibu, mungkin karena ada perbedaan waktu Indonesia dan Chicago, kita harus berhenti untuk pertanyaannya. Sekarang saya akan menyimpulkan beberapa hal. Ada beberapa masukan dari teman-teman dan informasi bahwa sebenarnya sudah ada sirkumsisi yang dilakukan di Papua. Itu sudah ada promosi dari 2013 sampai 2018, namun programnya sudah tidak dijalankan lagi. Ini juga ada beberapa masukan untuk memperhatikan informasi dan faktor budaya dan agama untuk pendekatan ini. Selain itu juga ada concern tentang izin secara informal kepada Kemkes ataupun Dinkes setempat terkait kemungkinan visibilitas untuk pelaksanaannya. Oke, lalu mungkin ada beberapa kesimpulan yang bisa saya tarik dari perbincangan kita hari ini, yaitu sunat laki-laki ini sebenarnya bisa mengurangi HIV sebesar 57% dan dapat dipertimbangkan sebagai salah satu program pencegahan HIV yang komprehensif. Selain itu, kita harus memperhatikan yang tadi disampaikan oleh teman-teman juga, bahwa ini tidak berusaha untuk merubah budaya maupun agama, sehingga kita harus memperhatikan cara penyampaiannya agar bisa diterima tokoh setempat atau bahkan dianggap sebagai pemilik program untuk intervensi ini. Lalu intervensi ini juga bagus untuk dilakukan di Papua karena tingkat HIV yang tinggi, namun angka sunatnya masih sangat rendah, sehingga perlu dipertimbangkan untuk dilaksanakan. Nah, lalu PPH akan melakukan penelitian untuk di Papua. Mungkin nanti akan ada beberapa teman-teman di sini yang juga dimintai bantuan dan kerjasamanya. Nanti mohon untuk bantuannya dari teman-teman. Oke, mungkin itu aja kesimpulannya karena keterbatasan waktu. Demikian lecture series pada hari ini. Kepada Prof. Belly kami ucapkan terima kasih atas waktunya. Selanjutnya Mbak Lenggo mungkin ada pesan-pesan atau foto. Silakan Mbak Lenggo.
Oke, terima kasih Erik atas fasilitasinya dalam sesi paparan dan diskusi tadi. Dan terima kasih juga untuk narasumber kita, Bapak Prof. Belly, yang telah menyampaikan materinya dengan sangat menarik. Semoga dapat bermanfaat bagi kita semua. Dan juga terima kasih untuk Bapak dan Ibu yang tadi sudah memberikan komentar, saran, masukan untuk penelitian Prof. Belly di Papua nanti. Dan terima kasih juga sudah hadir bersama kami di lecture series hari ini. Mungkin untuk sesi terakhir sebagai penutup mungkin kita akan foto bersama terlebih dahulu. Mohon izin Bapak dan Ibu mungkin bisa mengaktifkan videonya bagi yang berkenan. Saya akan screenshot. Mohon waktunya sebentar. Ada beberapa slide yang akan di screenshot. Mungkin untuk yang pertama, saya pandu. 1, 2, 3. Untuk slide berikutnya, 1, 2, 3. Oke, selanjutnya. Oke, yang lain sepertinya tidak mengaktifkan kamera, jadi sudah difoto semuanya. Baik, sekali lagi kami ucapkan terima kasih banyak untuk Prof. Belly dan Bapak Ibu yang sudah hadir pada lecture series kami hari ini. Akhir kata saya ucapkan terima kasih dan mohon maaf apabila ada salah-salah kata. Sampai ketemu di lecture series ataupun kegiatan PPH berikutnya. Terima kasih.
Thank you all very much.
Terima kasih, Prof.
Thank you, Prof.
Thank you, Dr. Belly.
Thank you.
Nice to see you.
I hope to see you all.
Terima kasih semua.
Thank you, Prof. Thank you.
Thank you.
Thank you, teman-teman semuanya.
Thank you, Pak Sefnat.
Ini ada sahabat Mozart dan Teh udah lama nggak ketemu.
Salam hormat Bang Sugi.
Siap, siap. Udah lama nggak ketemu kita ya.
Ya.
Lagi nyari formasi untuk pertemuan.
Mas Lahadianto, selamat siang. Oh, ada Mbak Eka juga. Halo Mbak Eka.
Pak Dli. 1000 nih. Patli udah dapat ikan berannya.
Masih ada Daud juga itu, si Daud.
Oh ya.
Di pulau lagi musim angin, Pak.
Oh, mantap. Bawa ikan yang banyak.
Oh. Siap.
Tinggal dikerukin aja.
Oh.